don't need to introduce David Levine from Montreal. Thanks for coming, David. The audience is yours.
Thank you. Okay, get this up. Thank you very much, Anton. Anton promised me an audience of 5,000. That was before he canceled the webcasting. So now I have to be a little more intimate. If there are any questions along the way or something that I say, let me know. Sorry, that's okay, as long as he takes care of it and not me. What I basically want to do today is very briefly at the beginning of my talk tell you where we are in Quebec at the present time. The reform that was implemented in 2005, where are we now to 10? So a bit of a description of the reform. After that, what are the results? And basically what have I learned from 5 years of trying to put a system in place in an integrated care model. And hopefully through that explanation, you'll get a better understanding of what we're trying to do. A new law was put forward in Quebec last Thursday. It'll go to the National Assembly. It's gone to the National Assembly. It'll be debated in January. It's a law on governance. So it deals with the issue of what are the degrees of authority in each of the 3 levels of governance within the healthcare system, giving a fair bit more authority to my agency in terms of managing the system. And one of my real things these days, and I said to Anton, I'm going to write a paper on this one, is how do you manage a system as opposed to managing a hospital? And is a system managed like a hospital? Given the hospital is a professional bureaucracy, is a system a professional bureaucracy? And in our particular case, I believe it is. I'll talk to you a little bit more about that. And I just want to see. Yeah, that's the way. So what are the objectives of the healthcare reform that we're trying to introduce in Quebec? Very briefly, we want to improve the health and well-being of the population. Common objective. Every reform has it. We all say it. Does anybody do it? The change here was that specific mandates were given to new organizations to really deal with that. And the example I give, if you have a 200,000 population, that is your responsibility, and they're consuming tobacco at 23% of the population, and your objective is 20%, that objective will be part of an agreement that I sign with the CEO of that institution responsible for the population of 200,000 to reduce that to 20%, and that CEO will be measured on achieving that objective, which the new law gives me, the head of the agency, along with the chair of the board, the authority to evaluate that CEO, and hence whatever bonus he might or might not get. So there is a move towards really implementing health and well-being of a population. Bring services to the population. Very basically, what does it mean? Take the money out of the hospital, put it in the community, and at the moment, I mean, it's beginning. We've taken about 150 million out of the Montreal hospital system, put it in the community. We have a long way to go, but that's what that phrase means. So it's a very significant change within the system. Facilitate the use of services. We're really looking at accessibility and continuity. How do we get 24/7 coverage in the community? How do we get evening on call? How do we get people out of the emergency room? How do we get moving from one level of care to another? We want to look at managing care for the vulnerable or chronically ill patient. That's the focus. That's where the cost is. That's where the quality of life issues are. We really must be able to manage that better. Improve the quality of care. Huge issue, always been mentioned. we really need to keep focusing on it. If you don't keep focusing on it, we forget about it with all the other issues, and probably one of the biggest cost issue we have. Obviously, the last one, improve the control of costs. So what did we do? It was basically a populational responsibility. Quebec was divided up into 95 population areas. Montreal divided up into 12. My population areas are anywhere from 150 to 220,000 people. The island of Montreal is about 2 million population. That's the responsibility of my agency on the island of Montreal. The hierarchical provision of services meant get primary care up and running and out of the hospital, and get our specialists who are doing a huge amount of primary care. You know, if you see a cardiologist for a heart problem, you'll see that same cardiologist for 20 years. Probably 19 years and 11 months is primary care. You shouldn't be seeing the cardiologist. You should be seeing a GP in a family practice group that follows you for a multitude of other problems other than your heart. And they should all be looked at together. As we go from there, what did we do? We created a new organization called the Health and Social Service Center. It's a new concept of integrated services. What we did was we took the hospital, we took long-term care, rehab services, home care, mental health care, social services, community organization, put them all together into one institution, one CEO, one board. Merged over 70 institutions on the island of Montreal into 12. So there are 12 networks. Now the problem on the island of Montreal is only 5 of my 12 networks have a hospital. Because the teaching hospitals all said, that's not our business. We teach, we do research, we're big, we're important, you better keep us separate from the remainder. In my opinion, an error. I didn't fight the minister. Couillard was here a number of times. This was his reform. He said, David, politically, we can't do it. I said, this is going to come back to haunt us. It haunts me today in terms of my ability to do the kind of integration I want, because the primary care needs to have that direct access to the hospital in a very rapid way. Those that have a hospital in their network, better performers than those that don't have a hospital for their community. If you're outside, and I've said it a number of times in Ontario, I think the hospitals could be the noyau, the cornerstone of this type of an integrated network, given the influence of hospitals within the Ontario environment. So 12 on the island of Montreal, that's the way Montreal is divided. And we do a in-depth study of the needs of the population on the island. If you take a look at this area here, compared to this area here, it's a very well-off area. You have a lot of great homes along the water here. For 1,000 births, you will have 17 of women, you'll have 16 for women under 17 years of age. Here, very low economic center of the city, you'll have 57 births for women under 17 years of age. And for a child born to a woman under 17 years of age, the life path of that child is completely different than the life path of a child born to a woman in her 20s or early 30s. And so each of our networks, and those are the colored areas, are responsible for the population in their area. So this is 220,000. They're in charge of this area. There's a hospital here. Now the hospital takes clients from over here, take clients from over here. I have to adjust the budget in terms of the volume of activity of that hospital, because they don't only give services to their area, okay? If we take a look at what is their mandate of each of these networks, their mandate is to manage and evaluate the health and well-being of the population. So if you have 180,000 in your population, you need to know where the elderly live and who's elderly. This summer we had a heat wave, chaleur accablant we call it, and we were able to tell the fire department where the elderly live, and the fire department went and knocked on the doors of the family. This is when you have 3 days when at night it doesn't go below 24 degrees centigrade. So you were able to follow that up for your community. Manage the use of services by the population. This is really hand-holding. So you take the population, you hold their hand, and basically what we want is that all booking of all lab work, radiology, etc. is done centrally. If you get a script to get radiology, you call one single area, they do all the booking for you. Hopefully it'll get to the point where you book yourself online. And to do that, you have to make available those blocks of time. Our difficulty is, as I said, the major hospitals, which provide almost 80% of all diagnostic services, are not integrated into the networks. And they have their own interests, their own business, that of their physicians. Manage the services, obviously they have to manage. So budgets are now, instead of being small organizations, these are all organizations of 200 million plus. We're talking 3,000 plus employees, and so they have a management team that is now much more significant than the 70 institutions all over the island. Within this network, we don't have the very, very specialized services of intellectually handicapped or physically handicapped. There are still a number of institutions separate from there. Overall, I have 47 institutions on the island of Montreal, 12 networks, 8 teaching institutions, making 20, and then there's another 27 institutions, some of the ones that weren't integrated. For example, the Polish, Chinese, and Jewish long-term care centers were not integrated because they have a regional mandate. So they have a regional mandate of services, and the agency controls the admission to our 14,000 beds on the island of Montreal centrally at the agency. And then is develop a local network of care. Now this is a local network. The real issue was if you have a territory and there's 200,000 population, well, you have docs in your territory, you have pharmacists on your territory, you have the schools on your territory, you have a variety of other players. How do you bring all those players into a network? So part of your mandate is to create that network. And so we've been doing this now for 5 years. At the beginning, the most important thing that I said to the team, I was involved in the choice of all the CEOs for all those organizations. I sat on the selection committee. At the time, we had influence. It's a selection committee of 5 people, 3 from the board, 1 from the government, 1 from the agency. The government rep and the agency rep tend to really be almost one for all intents and purposes. The new law says that to choose the CEO, either the government rep or the agency rep has to agree. In the past, that wasn't the case. It took 3 people on the recommendation committee to send the name of the CEO to the board. So that has given another level of influence, but I was never confronted with that particular problem. It only happened once that I wasn't in agreement with the CEO that was chosen. Happened to be in a hospital, happened to be in a youth center the managed care. So Montreal had to come up with a vision. So I got the CEOs together and I said, what is going to be our vision? It's not our vision, it's your vision. It's the vision that you have to sell to your board. It's the vision that you have to sell to your team. It's the vision, if you accept it, it becomes the overriding vision of what we're trying to achieve. The same way any CEO in any organization would say, what's the vision for our organization? Get the board and get all the players on side. So everybody agreed that the key element of the vision was to develop a managed care model. So this is chronic care management, the Wagner model out of Seattle, mental health model, so it is managing mental health at the appropriate level, community mental health, okay, secondary level mental health in outpatient environments, and the hospital or the tertiary psychiatry mental health environment. And the continuum of care for the elderly, managing the elderly population from the very first indication of Alzheimer right through to palliative care and passing away, you manage the care of the elderly. The second component of the vision was putting in multidisciplinary teams for primary care with a rostered population. That became the key. I believe it's the key to success of any reform and of a healthy healthcare system, and we're in the process of doing that. I'll give you the results in a moment from the last 5 years. The third part of the vision, everybody agreed upon. It was really important for everybody to agree because I took money from the region and I invested it in IS for the region, but the money I took was their money. See, I don't have any money. The money is always their money. My budget, the Montreal budget is 6.1 billion. My agency's budget is 20 million. I run what I do with $20 million. The system is 6.1 billion. So if I take money from the 6.1 billion, I need to get some approval somewhere, otherwise everybody's going to complain. So we were able to do that, and a unified and computerized medical health record became and is today a real focus. The fourth element here was, and this one has been the hardest one to implement, empowerment of the population and the individual to manage and direct their care needs. This one's very difficult in the sense that you really have to reach out. You have to put in the information systems to the population. You have to have the training. BC has an excellent program for self-management at the moment. They've been doing it for a number of years across Canada. We're going to try to implement that program in Quebec. But there's a lot of work to do in that area. Three other elements: evaluation and measurement of clinical and administrative, which are financial outcomes. For me, it's the clinical outcomes. It's really moving to measure of clinical outcomes as the vision. If we want to go to a volume-adjusted funding for our institutions or our networks, we need to have some outcomes. I can't just do it on volume numbers. We need to know that it's doing something. The next one is really the focus on the workforce as part of the vision that we're trying to achieve. And we have come up with a plan that was approved by everybody and is now being implemented across the city. Took about, about 8 million out of the budget overall for the island and said, here's this, we're going to invest this in areas, and it's not a huge amount, we're going to invest this in areas where those type of activities are being introduced within organizations. Leadership and organizational change needed to implant the vision. Clinical leadership is probably our biggest issue. Docs and other clinicians don't want to be leaders. They don't want to drive the change. They don't want to drive the system. And what I need are clinical leaders really trying to implement what we want to do. So what are the results? This is what I really want to talk about. 5 years, 205, 210. What have we been able to do and what have we learned? The very first one is that we were, I believe, developed a successful system management strategy leading to joint management of health and social services. Again, social services in Quebec are included. That's why when I told you community organizers, etc., that's part of what we do. We deal with the itinerant population. We deal with issues of prostitution. We deal with, I mean, those are all part of the same agency. What happened here is that instead of being a multitude of individual organizations, when we looked at this in Montreal, and from my perspective, I really said, how can we develop a system where everybody works together? And so the very first thing I did was, well, if you're CEO of any organization, you have your management team. So I said, who's my management team on the island of Montreal? And the management team becomes the CEO of the organizations. So because we had just created the 12 networks, and because I had been involved in the choice of all the 12 CEOs, I said, well, why don't I have a management team meeting like I did at the Ottawa Hospital or Notre Dame Hospital that I ran, and I said, well, look, you guys, for the first year, are you willing to get together once every 2 weeks on a Wednesday morning for the management team meeting with me? And these are all CEOs of their own organization. So all 12 said yes, because nobody really knew what to do or how to put their organization together. I'm not sure I'd get the same easy response today, but we got it at the time. And after 12 months, we had met at least 20 times in that 12-month period trying to implement the reform. They all asked to continue the management team meeting. We then integrated the 8 teaching hospitals into the management team meeting, and now the management team meeting are the 20 CEOs once a month and the 12 once every 2 weeks. So once the 20 are together, and then 2 weeks the 12 are together, because the 12 have different issues dealing with their home care issues and other issues like that. The new law came down last Thursday In the law now, it says that each agency must have a management structure. So they took the model that we had implemented in Montreal and are trying to introduce that, and that's been introduced in the law. I was much happier not to have it in the law and be able to do it. CEO gains his authority from the credibility he can introduce, the same way I gain my authority, that people are willing to play around the table. And they'll do it if I help them, if I can provide services to them, if I can deal with the issues that are of concern to them. So this is probably, I think, the most interesting notion is the development of a system. Now, you might say that Alberta had a system when Stephen was there, and Stephen ran the whole place. So it's one system, one CEO, one board, running the whole province. For me, that would be a nightmare, really. I'm very happy to have CEOs and their boards. They are very involved in their organizations. They're very committed. They're very present. They're the ones really running the show. All I'm trying to do is get everybody to row in the same direction, okay? And get people talking and concerned about the same issues. If I didn't have CEOs in each of the organizations, I'd never be able to. It would become too bureaucratic. It would become really like the ministry trying to run everything. So you really, I believe, must keep very engaged CEOs and very engaged boards stimulating those CEOs in their organizations, but you need a system approach if you want to really achieve the objectives you're looking for. So we had the successful implementation of the 12 networks on the island. I think 5 years later, some of them merged, 12 organizations into one. So you can imagine 12 systems of pay, 12 systems of information. They all had a director of this, they all had a director of that. So in the first 5 years that was all squeezed together, they did suck out money that they were able to use for clinical development. So that was a positive thing in those first 5 years. What they weren't able to do was change the clinical modalities. So there was structural change, there was no new clinical change. And so the clinical culture hasn't changed yet. That's going to be our challenge for the next 5 years, changing the clinical culture. We, because of the primary care objective, have implemented 45 primary care groups. They're not as sophisticated as your primary care teams in Ontario, which each got 1.5 million to invest in the appropriate staff. These were groups that each got about 400,000. There were anywhere from 7 to 12 physicians grouping together, and they had to be open 12 hours a day, so at least we got some better coverage. They had to have on-call and with appointment and walk-in environment so the patients could have better access. And we provided with that funding 2 nurses into those environments. What we're looking to implement today is a real medical center, the primary care team, 15 physicians, 15 professional staff, 15 support staff. It's again about the 1.5 million it takes to put that together. Each of those 45 centers has radiology capacity. And one of our criteria was that they were implemented in an environment that had radiology out in the community already. That was part of the criteria. And so that has worked. As far as I'm concerned, we haven't yet really improved accessibility. We have as many Montrealers without a primary care physician as we had 5 years ago. What we were able to do is get vulnerable patients attached to a physician. So each one of the 12 networks, if you're a vulnerable patient and there's a category listed of vulnerable patients and you call up, they will get you a doctor. And the doctor will accept you because they get more money if you've been labeled a vulnerable patient for each time they see you. So that was one place where funding helped, and so our vulnerable population is getting much, much better accessibility. The general population is not. They're not getting it yet. What else? That was the process of managing vulnerable patients. I just explained that. There was the joint design approval and the implementation of integrated medical networks. So those are the 2 we now have up and running. I have 2 of these environments, 15, 15, 15. They are 2 academic environments. The reason they're academic is because the staff, professional and medical, did not know how to work together. I went to the two deans of the Faculty of Medicine, McGill, University of Montreal. I said, do you have programs that teach your residents and interns, and do you have programs in nursing and programs in physiotherapy where they all work together and they sit in the same classroom and they learn that in this particular disease, here's what the doctor does, here's what each of the professionals do, and here's how you should work together. Both of them said, no, we don't have any of that yet. And I said, well, don't you think you're about 5 years behind the times, and this is something you guys should have been doing a long time ago? Aren't you supposed to be the leaders in what's going on? And they said, yes, well, we better get to do it. So University of Montreal has now got programs up, and they are integrated programs, and the deans of nursing and the deans of each of the various faculties, professionals with the physicians. Biggest resistance, medical students. I don't want to spend my time with a physiotherapist or a nurse. I mean, I've got busy stuff to do. I got to get all my learning in. I've got to get, my exams done. So, it was big enough getting the 4 docs working in a team to solve a problem, McMaster model around the table. Can you imagine now with 8 around the table when there's a nurse, a nutritionist, a social worker with the docs, and they're trying to deal with the particular problem and patient. So that's what we need to introduce. The 2 I have up and running are academic. There to develop the protocols for how to work together in a team. That's where the interns and residents are going, and hopefully I can roll that out to the number of family practice teaching units we need in that kind of environment. As I said, I need 60 for the island of Montreal. Each of those centers will have 30,000 rostered population. It's about 1.8 million is what we figure we need rostered on the island because the population fluctuates back and forth. And that's our objective to work on over the next 5 years. My problem, where do I find the money? And now, every time I keep saying, well, I'll take the money out of the regional budget, I'm beginning to get a bit more resistance than I got in the past. That's becoming an issue. Implementation of citywide IS platform. There's a story here. It's a story that began a number of years ago. McGill, University of Montreal, which are 2 of our major teaching hospitals, each of which is in the middle of a $2.5 billion build for a new building. Our Saint-Justine Hospital, Children's, is a $1 billion build. Just there alone, I have $6 billion worth of construction over the next 6 years on the island, probably over the next 7 years on the island of Montreal, and that's independent of what the Jewish is doing at 325 million, et cetera, et cetera. So the sum total build on the island over the next number of years is huge. What I was able to do when McGill and University of Montreal went out for an IS system and they went to tender, I said from the agency, we'll go along with all of that, that's fine. Just put in a clause that if we want to piggyback on this particular contract, we can. So all the people building knew that the agency could piggyback on the contract. And once McGill and the University of Montreal, who have now 1 chief information officer for both of those teaching hospitals, put together 1, and they bought this particular system, I took a look and met at the management team meeting, and I said, you guys, you interested in trying to look at this system and see whether we roll it out to the whole city? And in the end, what we did is we negotiated for the rollout of the Oasis system complete, which is simply a viewing platform to integrate all the components, come up with a common identifier within each of the institutions. Once that's done, it's going to be a lot easier to connect all the pieces. And the Oasis system was to be set up within all our institutions. So that's 47 on the island of Montreal. The rehab centers set it up in the long-term care centers. So when you go to the computer and you log in, you're going to get the exact same format, the exact same screen in all of our institutions throughout the whole island of Montreal. So any nurse moving from any institution, any physician moving from any institution will get the exact same thing. Included in that contract, which we spent a bit of time negotiating, was the ability to roll out to other agencies within the province of Quebec, and the Montreal agency has now rolled it out to 2 other agencies in the province of Quebec, and we have 4 more that we're negotiating with at the moment. So in the end, a large portion of Quebec, I'll say probably 65%, will be on this same particular platform when it's finished. This is a rollout as well into the primary care physician's office, and that rollout, the primary care physician can choose whatever they want. They can go with this particular platform. They can go with other platforms because it's private. In the public component, I will roll out this particular platform. Included in this was the numérisation, digitizing all data in the system included in the contract. So when you do a large contract, it's a 10-year contract, you can get much, obviously better cost to your whole system. And we have a very strong implementation team. And the company now is a large company implementing it. And as I said to somebody up there, they're very concerned about making sure they do it right, because the company would not like David Levine saying it's not working. This company is not doing a good job. So you have a strong influence in getting the work done and on time. The reorganization of post-hospital rehab services. We regrouped stroke patients. In our 11 rehab centers, we regrouped in 2 all stroke patients. We regrouped patients for very specific types of care. This was a major change because everybody was doing a bit of everything. And so that needed the kind of agency influence to be able to get to that. That has been done over the last 5 years, and I think everybody is very pleased, especially the organizations themselves, that were able to concentrate in certain areas of expertise and really make sure they're doing best practice. Reorganization of long-term care services. Joint design approval and beginning of implementation. I have 792 long-term care beds in acute care hospitals. Those were beds that were historically there. We're in the process of closing all of them, all the beds. When I close them, and those 800 beds of the 1,400 on the island were under the jurisdiction of the hospital. So as soon as the patient finished their acute care treatment and the hospital had one of those beds available, they could move their patient into the bed, and it was the medical team in the hospital that followed up that patient. We're now closing those beds. The hospitals wanted this. Why? Because we gave them a guarantee that 72 hours after they declared the acute care finished, the patient would leave the hospital. Now, we're respecting it in some cases and not achieving that goal in others, but it is the goal. And the idea is that acute care hospitals and acute care hospital, their beds got to roll, and they have to roll because we get rehab patients out, we get long-term patients out, and that becomes the responsibility of the remainder of the system, the networks. It's not the responsibility of the hospital. And that's part of the shifting in the hierarchy of services of literally getting some of the money out of the hospital. So I say to the hospitals, well, that's going to affect maybe some of the money of the kind of rehab you did, of kind of the stuff you did. We want you concentrating on acute care. And that becomes the message. So I've closed about 500 of the 800 beds. I have 300 left. What we found fascinating is that as we close the beds, we set up evaluation centers, because as the patient comes out, and these are patients that need long-term care. So it's not the patient that leaves the hospital and goes home. This is, or leaves the hospital and goes for home care. This is, they say, the hospital says, this patient can't go home, needs long-term care. So now we start evaluating those patients, and we find that a nice portion of them don't need long-term care. That what the hospital was doing was this is the way, boom, boom, you know, and long-term care, someone else take care of it. So now that we have teams that are much more focused, and what we're implementing into the hospital is a program of managing the elderly within the hospital. What we want to introduce, you're not allowed to leave an elderly patient lying in a bed. You must put that patient in a chair. You must walk that patient. You must, those good hospitals that know what to do from the time you walk into the emergency room to the time you leave, that elderly patient moves. That elderly patient never sits still as much as possible. Now, I mean, we're implementing that very slowly because it's much easier for staff and much easier for everybody else. You take the patient, you leave them in their bed, but that's where they get their bed sores. That's where you're in the hospital 3 days for an elderly patient, and you age tremendously. And you lose mobility, you lose autonomy. It's amazing. So that's a big focus in this area, implementing that throughout the hospitals on the island. There was a reorganization of mental health services. Montreal spends $325 million on mental health in our 5 psychiatric institutions. What I did is took $60 million out of that budget from the hospitals, moved it in the community, and each of the 12 networks set up primary care mental health teams that are there to respond to the needs of the primary care physicians. So the primary care physician sees a patient, depression, sends the patient to the primary care team in the network, not to the hospital, not to the emergency room of the hospital. And so that's a major change. Again, 50% implemented, huge resistance from the hospitals, huge resistance from the psychiatrists and the teams that had already built up. They were doing all the outpatient stuff. And what they say is the GPs and the other teams, they don't have the competency to do this. We're afraid to send over our patients to them, etc. So it has been an uphill battle on that one. 50% is done. Implementation of a chronic disease management model. Well, what we want to do here, we took 5 chronic diseases. I said to each of the 12 teams as we sat around the management table, how do we go about implementing? Who wants to do pilots? I picked up a couple of pilots, a diabetic pilot in one of the centers that had a hospital and funded the pilot. They put it together, they put the team together, and they became a very good chronic care management team, getting references from the family physicians into the team. They'll see a patient anywhere from 3 to 5 months. They'll follow that patient. Patient then goes back to the primary care physician. It's a diabetic patient at a more serious level, insulin therapy, etc. It's not, and they have education training. That program now has been running fairly successful, and we've just rolled it out and sent out a press release the other day that that program now exists in each of the 12 networks. And then we're moving to pulmonary obstructive disease, hypertension, etc., etc. So I will hopefully have 60 programs up and running, 5 in each of the 12 networks, covering the 5 chronic diseases, so that the primary care physicians can move in. You need the specialists from the hospital prepared to participate in the team, and your management here is to keep the patient out of the hospital and out of much more serious problems. We were able to attack, like you did in Ontario, surgery wait times. What we did is we grouped high volume services. So we did hips and knees. So I have now, we went from 2,400 hips and knees to 5,500 hips and knees, and we were able to concentrate them in environments. I took a small hospital that had 5 ORs, and they're now doing 700 hips and knees. Physicians coming from the teaching hospitals, going there, dedicated beds. They aren't the most complicated of hips and knees, but they're getting them done. In and out, very efficient, and the majority of them are going home, not to a rehab center, and getting their rehab at home. So that whole piece came out. Cataracts, we went up from 20 to 28,000 cataract surgeries. Everybody gets their surgery within 6 months. In Quebec, they did a law, a guarantee. You got to have your hip and knee done within 6 months, your cataracts done within 6 months, cardiac intervention within 1 month, and those are the targets we have to achieve. Our minister became very involved in surgery wait times and set up a data collection on a weekly, bi-weekly basis, gets the list of every patient on every doctor's waiting list and the reason they're on the waiting list. And we remove patients from 5 years waiting, 4 years waiting, 3 years waiting, 2 years waiting, and it was really put the system back in order, not being the sole purview of the surgeon himself managing in that environment. The managing of emergency room services, very big issue, long wait times, really inappropriate care. We compared Montreal. I have about 850,000 visits per year to our emergency rooms for our population. Similar populations under a managed care model where primary care is the focus. Kaiser, for example, for that same population will have 450,000 emergency room visits. The rest of the population that in Montreal goes to the emergency room would be served elsewhere. So we're looking at removing a incredibly high cost, high interventioning environment to a much better environment for patients. The joint managing of emergency room services, one, based on data collection, two, getting the patient out of the bed as quick as possible, getting your consultants to really get involved. We're introducing a bed management system, and eventually I'd like to go to a citywide bed management system. There's some very interesting products out on the market today to do that. We're negotiating to a very interesting pilot in one of our major teaching hospitals at the moment. A firm called Mekison has got a very, very interesting product on the market. My concern is not the product. My concern is, can the hospital have the cultural change that will use the product? Because if you put in the product and nobody uses it, you've wasted a lot of money. And a lot of what we do is like that. We go for the product, we think it's going to be the panacea, and the staff and the physicians and everybody else, they just don't follow it. So you've got to be very, very vigilant. Do a pilot, see if we can get the organization involved, roll it out to the rest of the city. If I can do that same kind of thing, if I could have the whole city on a bed management program, and really sort of in my office, or have the portrait of every single bed on the island of Montreal, and every bed that's free or not free, every bed that's available, not available, it'd be fantastic. I mean, that's really a good way to see it. But at least let each hospital have their control room with a portrait of every single bed and what's happening in every single bed, and do some really high-end bed management would be fabulous. But it isn't the tool. It's once again the people and the cultural change that will allow the tool to be used. If you don't put it in, and for that you need case management in the hospital. You need to be able to manage each of your patients in the hospital through their course of care. Because that's expensive, manage the complex ones. Leave the other ones to flow through the system the way they flow through anyways. Manage the complex ones. We have a 30% increase in obstetrics, so we went to a system-wide obstetric management, and I've had to increase birthing in 2 of our centers that were at 2,500. They're both going up to 4,000 births, and basically we're going to have 4,000 births. We're going up to 34,000 births on the island of Montreal, and so that's being concentrated in a number of environments for very good throughput, but it has allowed a system-wide way of looking at where do we need new birthing spaces. And then, because I'm responsible for placing physicians, the number of new physicians that come in, it's not each individual organization that says, we need a new obstetrician, they have to apply for this. They submit a request. We have a certain number of physicians. Those physicians are distributed, but they're distributed according to a clinical plan. So if I need birthing out in that yellow area at the end of the island of Montreal, then we will put obstetricians out in the hospital, and that's where they will get the slot for that physician. Better integration of community groups. We have 650, it's now up to 700 since I noted that one. We have 700 community groups that I spend 120 million on and probably get $500 million worth of work out of that 120 million. And if I didn't have it, we'd be in trouble. The very significant input, and because we have that view of all that goes on, each of those groups is accredited. There's an accreditation process in the system. Implemented public health prevention and promotion programs at the local level. We had set up 12 health education programs in each of the 12 networks, and the physician writes a script to the patient. You're overweight, go to the education center. They take the script, they go to the education center, they provide it, the education center takes them on and follows them up. Biggest problem, getting the doctors to write the script for their patient and convince the patient to go. So that becomes the real issue. Implementing results, we did a health promoting health centers. You have some of them up in Toronto now. That was part of our commitment to ensure that health prevention and promotion was involved. I'm going to go a little quickly on this. We're in the middle of optimization projects, major effort to save significant millions of dollars. I have a $250 million clawback of my budget over the next 3 years. So I've been told that the Montreal budget of now 6.1 million will now be clawed back $250 million over the next couple of years. It'll increase indexation, everything every year, so the total amount of figure will be way up there, but it's going to be 250 less than what is really required to maintain the system at the present time. So we already have to start planning. We're hoping for a 10% increase in bed management, home care software, which we want to introduce with a reorganization of home care, looking for a 20% increase in the number of visits of our nurses and staff into the home. We're going to centralize all the servers in all of our hospitals into a single environment. The study of that is just at the moment coming out to see whether it's economically feasible. It costs about a $24 million total investment to have 2 mirrored environments where all the servers are collected together. Will save about $8 million a year. Pay itself off in 3 years, and every year after that we save $8 million. So, and that's done on a citywide basis. Centralized IP phone system. We're going to go to an IP and put that out throughout the whole city. Centralized purchasing. We buy for $1.5 billion. I probably have about $500 million on centralized purchasing. Biggest issue here, getting the docs and everybody to agree on standardization of products, etc. 6-year balanced budget in the island of Montreal. This year I will not be balanced. This will go out on a video somewhere, and I think someone will see that within the ministry. We're not going to make it. There's just too much going on. I'll give you an example. Last year I had to borrow $22 million from the surplus of some of our institutions. So I took away their surplus, $22 million, and I loaned that $22 million to those hospitals that were in deficit. They have a signed agreement to pay that back. How do they pay it back? I removed the money from their budget at the beginning of the year, so it's automatically paid back. They just have that much money less in their budget the following year. So it's not a great idea to take a loan. Really, it isn't. And I guaranteed to each of those institutions that I borrowed their surplus, that surplus is available to them on a moment's notice the minute they ask for it, and I guarantee that that money is there. But that's how tight we were last year to balance the budget, because Montreal is a single budget that I have to ensure ends up being balanced. What are the barriers? And I'll finish off here. Primary care is still considered separate from healthcare delivery. We're still in a hospital-centered model. We're not there yet. Silos of care still exist, even though we're integrated. The clinical silos still exist. The structure is there. The clinical silos still exist. An integrated computerized medical healthcare record, it's going to take another 3 years before I have it up and running throughout the whole island of Montreal. There's no clear common vision of the action to be taken that have been fully accepted by all stakeholders, especially the professionals. The professionals are not yet there. The clinicians are not yet there to an integrated managed care model. They're still independent, autonomous workers, and that's the biggest cultural change. There are multiple zones of power and influence in a political environment. Healthcare is political. I could go on for many hours of what are the zones of power in healthcare? How do you define each of the zones? How do you analyze the leadership of those zones of power? And how, as a manager, a CEO, you interact with each of those zones of power? And that is really 35 years for me of experience in how to deal with that. There are zones of power in the organization, there are zones of power outside. Media is one of the biggest zones. Biggest influence on politics today is media. The front page headline is stunning. I get phone calls. I have a whole team of 4 people only dealing with calls from cabinet, because Montreal is national, all the national newspapers in Montreal, everything that hits the thing is Montreal. I have a team dealing just with that. And they have to be prepared, and we prepare the answers to the questions in the question period at the National Assembly. So that's part of what we do, and that's just one of them. There are many zones of power. And then multiple professionals not trained to work in multidisciplinary teams. I mentioned that one. It's a very big barrier to what we're trying to do. Professional corporations are still protecting their turf. The various corporations, medical or non-medical, but the professional ones. And really, there's lack of strong medical, clinical, and unfortunately, I still think in many areas, administrative leadership promotes organizational transformation. It's really the strong medical, clinical that's needed. There's some very good administrative, but as far as a lot of the regions that other agencies, like the LHINs, they're not considered top priority. And so you become head of a LHIN, and then you look for your hospital, and then you move out and you go to become CEO of a hospital. It's not the LHIN or that is really considered the major player. And that is the end of the talk. Thank you.
Thank you, David. Calling bed blockers long-term care in acute care hospital is pretty sneaky, David. But you're not the only one with the problem, and I'm sure you know that. They're called alternative levels of care in Ontario. Who's got a question for David? We have a few minutes. Well, let's go way over the Ray's head. You know that last point you made about clinicians being in the way, David? Yeah. We just published a book called Lessons Learned in Changing Healthcare, 16 physicians telling how they made change. Available on the longwoods.com website for free. Merry Christmas.
I downloaded it and I'm halfway through.
Thank you.
Thank you for your email.
Hi, David. Fascinating talk. Two questions. One is any of this written up? Because I think it could be very useful for us to have some of the details on paper. But the other one is, who pays for care? Because an ongoing problem is that Canada Health Act privileges care given by physicians or in hospitals. And the minute you send somebody home, you have to pay for the care yourself. So do you have it that if you send people home to home care, if you send people to the community agencies, are those all from your budget, or do people then have to pick up a budget for things that otherwise would have been paid for from hospitals?
They're all from our budget. So the budget invests in home care. We do now about 49,000 clients per year in our home care system, about 1.7 million visits per year. We pay for all of those visits. Now, the family can purchase extra care. A lot of that care is, we'll also have a program where we pay for the family. The family then hires who they want, and they get the funds for it to pay, and the salary that they pay, it's a particular group, we try to support an increase. So it's now $12.25 for an aid worker or something in the home, and we will provide that funding to the family. They then purchase, but they can only purchase the number of hours of care that we have determined in the evaluation process. Our maximum hours of care are 35 hours a week, 5 hours a day, which might be a multitude of visits throughout that day. That's called intensive home care, down to maybe 1 hour a day if it's a bit of a bath. 50% of all our work in general deals with wounds, dressings, wound management, big issue, quality issue, cost issue, huge issue. So we have to look at that. I introduced a week ago to the management team, said, you guys, we got to do an evaluation of what's going on, wound management in the whole city. We've got to take a look at what it's costing all of us, and can we make in a more systematic way, you know, so there's wound management in the hospital, there's wound management in the system. So that's what we're trying to look at. To write it up, did a paper a little while ago, long time ago, called Revolution. It's in the, it's a Revolution to Healthcare. That gave you the description of the first part of the paper, the results, and a discussion of the results I haven't written up yet. I guess that could be another
question over here, David.
Paper, yeah.
Thank you very much for your talk. It was very interesting. I'm interested in the stress that you put on integration, and yet the chronic disease management model that you're establishing, it appears to be less integrated in the sense that you're talking about setting up 5 different chronic disease management programs within each of the 12 areas. And I wonder the utility of doing that given the desire to be integrated.
It's evolving that there should be a common core chronic management program with offshoots to what are the particular problems, so that the core of chronic management for the patient tends to be the same type of education, the same type of material, and that you then have your diabetic specificity, you then have your, pulmonary lung issues. So that's what we're looking at the present time. But I'm telling you, setting up each one of these is not an easy thing. Getting the people together, getting the docs to come out of the hospital, and these are specialists, to say we're part of the team, and they give their input, and they answer the nurse when the nurse calls, and doing that, because it's this mix of people from out of the hospital classic environment, and we want all of these to be out of the hospital, in a physical building that is not in the hospital. That's part of the requirement. And so that's to keep people out of the hospital, basically, is what we're trying to do. Yeah.
2 more questions, one here.
Thank you for your talk, David. I'm interested in the comment you made briefly at the beginning about well-being of patients, as opposed to health care of patients. And I'm assuming by that you meant a more proactive approach, because you talked about reducing the access to specialists when it's unnecessary.
Right.
I would be interested in hearing what's being studied and or done towards that end.
It's a very large part. I mean, we have I have this is separate from my budget, 300-person, 150 physicians, public health team. We do all of occupational health and safety, we do all of immunization, we do all of infectious disease control, we dealt with the pandemic and managed the pandemic on the island of Montreal and ensured the vaccination in all the centers throughout the island, vaccinated 1.1 million people during that period of time. We have special programs. Our focus is 0 to 5 years of age, maturity, scolaire, strong focus in that area. There's a lot of work, a lot of research from that team, both of which are installed in the university hospital environment. Big focus, and in each of the 12 networks, there's a public health officer in each of the 12 networks, integrated and often doing something else, like managing some clinical care environment. So that public health prevention, promotion is a big factor, and my belief is that it shouldn't be sliced out as a separate piece, but should be integrated in the whole continuum. My public health people are very afraid that if you do that, it gets absorbed and disappears, and want to keep it very isolated and protected, you see. So we have that debate going on, and we're trying to do it as much as we can. It's the only thing that's going to influence obesity. It's the only thing that's going to influence, whether or not the population stays a little healthier. Whole self-management component is part of that.
And one more question, David, right here.
Yeah.
Just trying to get our comparisons to the LHINs and their ambitions to achieve some of what you've described here. So, at least 2 LHINs now have a blueprint for 2020 that has pieces of what you described in terms of the hierarchical approach and the population-driven approach. There's another LHIN that's got a proposal out due this week for 2030 for a vision of the future. Yet they don't have the reform you described from 2005, and certainly not the most recent, with especially primary care under the same umbrella, and the integration with social services. It seems to me the LHINs, though, are trying to innovate themselves, and then maybe that'll get rolled across the province and the reform will catch up. Wonder if you've just got a point of view or some advice based on your last 6 years of experience, what are some key things that need to be kept in mind as they get on this journey?
I mean, I think you were very, very accurate when you said that LHINs have a much greater challenge because there isn't that level of integration. Hospital doesn't manage home care, the hospital doesn't manage long-term care, the hospital doesn't manage rehab care services. Should it be the hospital managing it? In the Ontario environment, the hospitals are so big and they're so dominating the whole healthcare field that it probably would be the easiest way to do it, and I believe the hospitals, the CEOs and their boards could definitely evolve to a hospital community integrated environment. The rest of the community doesn't want that. very frightened of the hospital taking over and being a much more acute care model. So as you saw, I keep saying get out of the hospital, get away from the hospital, etc. Would the hospital have that mentality if they were the center? I think that as long as your LHINs are hospital focused, as the rest of the pieces are not integrated together, they're going to have a lot of difficulty doing it, and they'll create bridges in their plan, and the bridges that will connect all the pieces, but there are a lot of bridges, and you have to maintain the bridges, and you have to repair the bridges, and you have to paint the bridges, as opposed to having it all integrated and you don't need the bridges, it's a solid paved road. And I think that's going to be the issue for trying to do integration in the LHIN environment.
David, we'll make sure this is online in about a week, and we'll let a lot of people know, because this was a fascinating session. Really appreciate you coming down. And the book you're halfway through, I thought I'd give you a hard copy.
That's
you can
so
finish it on
lovely.
the plane.
Thank you.
Those who have not seen or heard it, the table of contents is outside, and it is online at no charge. The hard copy, however, costs money. But I thought, David, in case you haven't seen it, this is the famous High Performing Healthcare Systems book that has hundreds of thousands of downloads. And I thought I'd give you a copy of that. Ross Baker is the editor-in-chief of that.
Thank you very much, Anton. Thank you.
So thank you for coming to breakfast with the chief.